GRACE, the global resource for advancing cancer education, is pleased to provide the following presentation on post-operative therapy for resected early-stage non-small cell lung cancer by Dr. Heather Wakelee, medical oncologist and assistant professor at Stanford University. Dr. Wakelee spoke at the GRACE Non-Small Cell Lung Cancer Patient Forum in Seattle in September of 2009, a program sponsored by OSI Pharmaceuticals and Swedish Cancer Institute.
So what I'm going to be talking about is adjuvant treatment or chemotherapy after surgery. Okay, so you've heard some about the TNN, so I'm just going to remind you. And this is a little cartoon, so I think it's easier to see. Stage 1 tumors are those that just have the tumor and it hasn't spread anywhere else. And we divide it up by size. The T2 tumors are those where it's spread into some lymph nodes, and the lymph nodes are those that are in the lung. And then the stage 3 tumors, at least the 3As, are the ones where it has started spreading into the center part of the chest or the mediastinum. So for stage 1 and 2, with surgery alone, the surgeons are able to cure 60 to 80% of patients. So that's pretty good, but that still means that there's 20 to 40% that aren't cured. We need to move beyond that. We need to be better than that. And there is a lot of controversy about what we can do to be better. We don't know if chemotherapy actually helps. And we'll talk about where we're going with some future work to try to improve upon that. For stage 2 with surgery, cures are in the 50 to 70% range, which again is not bad, but it's not good either. We've got a long way to go. And what we've learned in the last 5-6 years is that if we give chemotherapy after surgery in patients with stage 2 and also some stage 3 patients, we can improve the cure rates by 5 to 15%. And so that's what I'm going to be talking to you a little bit more about now. So this is a slide showing a survival curve, and what this means is that these are the percentage of people alive. So we start off with everybody alive, and then as time goes on, unfortunately, some people have their cancer come back and they die of the cancer. And what this is showing in pink are people who had surgery alone and got chemotherapy, and the orange is just surgery by itself. So you can see here that if you got the chemotherapy, the pink line, there are more people who are alive over time. So that's showing some help from the chemotherapy. And this slide takes a lot of trials that have been done in the 80s and 90s and pulled them all together. And we do a lot of this, what we call meta-analysis, or taking lots of studies and trying to put all of the data into one sort of conglomeration so that we're able to understand it a little bit better. But it didn't reach what we call statistical significance. And in order to reach statistical significance, this number, this p-value, has to be 0.05 or smaller. So this is called the LACE meta-analysis, and it took 5 of the trials that happened after that one I just showed you and put them all together. And it was nearly 5,000 patients that were involved in these 5 big trials. They were followed for around 5 years. And what came out of it was this 5% improvement in cure rate in 5 years. And that was statistically significant with this p-value of 0.005. So you add the extra 0, you're definitely statistically significant. One of the other things that came out of it was that it mattered by stage. What I've shown here are called hazard ratios. So these are ratios. If the ratio is 1, it means there's no difference. If the ratio is higher than 1, it means that the new thing you're looking at is actually worse. And if it's lower than 1, it means the new thing that you're looking at is better. So when you look at these, you see here for stage 1A, these are the small tumors, smaller than 3 centimeters, which hasn't spread anywhere. This number's higher than 1. And that tells us if someone has a stage 1 cancer that's small, that's been removed, the chemotherapy isn't helpful. It actually might be harmful. But if you have a tumor that's bigger, the stage 1B still hasn't spread, that's less than 1, but these numbers aren't statistically significant. So maybe it's helpful, maybe it's not. We can't tell for sure. But if someone has stage 2, meaning their lymph nodes involved, or stage 3, the lymph nodes in the mediastinum are involved, then you've got this number that's 0.83, which is definitely less than 1 and statistically significant. And so that tells us that chemotherapy is helpful for stage 2 and stage 3. This is a graph from one of those 5 studies showing that, where you can see the red line are people who got surgery alone. The yellow line is all the people who had surgery and chemotherapy. And you see here that there are more people alive who got the chemotherapy after their surgery than who didn't. And this is statistically significant. When you put it all together, what do the numbers mean? It means there's an 11% improvement in cure at 5 years. And when I talk to my patients about what is the benefit of chemotherapy for you, should you get it or not get it, I always talk about this absolute improvement in cure because I think that's a number most people can understand as they're trying to weigh, well, what does it mean for me to go through 3 months of chemotherapy? All of these trials included chemotherapy over about 3 months where you would get the chemotherapy usually about 4 times, so spread out every 3 weeks. And there are definitely side effects from chemotherapy. I didn't really put this in here because I'm going to talk about where we're going with newer studies, but side effects are nausea and vomiting, fatigue, the longer recovery from surgery. Some of the chemotherapy, there's hair loss, some of them there isn't. Some of the chemotherapy, there's potential numbness in the hands and feet, some of them there isn't. And so it's difficult, but people can get through it. We don't offer these treatments to patients we're worried aren't going to be strong enough to tolerate it. But for an individual trying to make a decision, they have to think about 3 months of going through chemotherapy. What does it mean for me? I'm able to tell them that it's somewhere between 5 to 12% or so improvement in cure. And for some people, if it's only 5 to 10%, it doesn't make sense for them to go through 3 months. But for many people, it does. I can never assume for any individual where their threshold is. For some people, they come and tell me, well, if it's only a 2% benefit, I want that. And other people come in and say, what do you mean? If it's not 15%, it isn't worth it for me. And so there's a lot of individual issues that come into that. But this is sort of the data that we talk about with folks. I put this in with lots of numbers because it refers to the differences in the size of the tumors. So there were further analyses done. Instead of just saying, okay, 1A versus 1B, which is at 3 centimeters, came up with this 4 centimeter number. And what this is showing is that if the tumor was small, under 4 centimeters, these hazard ratios again are 1 or bigger than 1. So probably no benefit from the chemotherapy. But if the tumor was larger, at least 4 centimeters in size, then these hazard ratios are lower than 1. So these are 2 of the trials where they did this breakdown. And so with this data, what we tend to do when we talk with patients about this is say, well, if you've got a bigger tumor, the chemotherapy is probably helpful. And if you have a smaller tumor, it's probably not. And so that's one of the factors that goes into the decision for each person. That's the chemotherapy information that we have. But I think what's more interesting to talk about is where are we going? We know that with surgery alone, we're still curing more than half the people with stage 1 and 2 cancers. And with chemotherapy, we can improve that a little bit, maybe 5 to 10%, but we've got a long way to go. So this is the future. I need to talk to you about what's called prognostic and then predictive factors. And prognostic factors are, we know ahead of time some people are going to do better. And the people who do better are those with the smaller tumors, lower stage of disease, and actually women do better than men. And a predictive marker is one that helps us figure out, are there treatments that might work better for this person than something else? And obviously, as a patient, I would certainly want to have my doctor tell me, well, these are all the choices, but I know that this one's better for you. And we're getting to that point, but we're not quite there yet. We still have a model of if someone comes to me and they've just had their cancer taken out, I can tell them, well, chemotherapy might help or might not, but I don't know which drugs necessarily are the right one for you. So we're trying to get to that point where we really can personalize the treatment. And so one of the first things to do that is this protein called ERCC1, which is involved in DNA repair. And to back up, the way chemotherapy works is by damaging the DNA of the cell, which then leads the cell to undergo what we call programmed cell death or apoptosis. That leads to cancer cell death and some normal cell death too, but more cancer cell death. And we know with ERCC1, this is a gene protein that's involved in repairing DNA damage. So if you have really high levels of it, the chemotherapy comes in, poisons the cell, but the high ERCC1 corrects that damage, and you might as well not have had the chemotherapy because you've repaired all the damage it caused. But if your levels are low and you get the same chemotherapy, you're not able to do that repair, and so the cancer cells are more likely to die. So that's the theory. So with ERCC1 negative or low, the theory was the chemotherapy would work better. And in this study, which is another one of the big adjuvant chemotherapy trials, that was true. And you can see that the group that had the chemotherapy, if they had ERCC1 low, they did better. Chemotherapy was helpful. And more so than for the whole study overall. Hazard ratio was lower, 0.76. But if people had ERCC1 positive or high levels, the chemotherapy didn't help. You were better off just having surgery alone and not getting chemo. So this is the first data that we have saying, well, maybe we can figure out who is more likely to get benefit from chemotherapy and who isn't. We're not quite ready to do this in real time for all people. This was just a trial analysis. They didn't have all the data, but this is now being incorporated into future trials, trying to prove that this is the case or not. And there are a bunch of other things like this that we're looking at for different chemotherapy drugs. So there's a protein called thymidylate synthase, or TS, which is helpful for the chemotherapy drug called pemetrexed. And RRM1 is also for DNA repair for gemcitabine. BRCA1, different for platinum and taxane. So these are just some of our chemotherapy drugs that we have. and some of the proteins that we're starting to look at to see if a person is more or less likely to benefit from that particular drug. And then another story is with the epidermal growth factor, or EGFR. There are drugs now that target that protein, and we found that certain patients have mutations where this EGFR protein is really, really important for their cancer. And these drugs work very well in those folks. And so that's one of the other things we're looking at. And the next slide, I'm not going to expect anyone to memorize, and I won't test you on, but just showing you that these are the trials that are now happening, trying to show whether or not we really can look at these levels of these proteins and decide, is this chemotherapy the right one for this person? Many of these are being done in Europe, and some of these are being done here in the US. And in all of them, what happens is the patient goes to surgery, and then the tumor is analyzed. And depending on the study, it's either analyzed for that ERCC1 protein, or the EGFR mutation is looked at, or some other genes are looked at, gene expression, to figure out if chemotherapy is going to help or not. So this is sort of the wave of the future. These are the trials that are ongoing to move us towards being able to more personalize or individualize treatments after surgery. Now I'm going to switch from that. That's more the chemotherapy into the newer drugs or the targeted agents. So lung cancer is what we call very heterogeneous. There are lots of different things that can cause lung cancer. We don't really have one magic bullet. There's not going to be one cure that's going to take care of all lung cancer. There are going to be different treatments for different people with the disease. Chemotherapy goes after DNA, as I mentioned, but there are a lot of other things that are happening in a cancer besides just changes in DNA. And this EGFR, epidermal growth factor receptor I mentioned, that's very important in certain lung cancers. VEGF, or vascular endothelial growth factor blood vessel formation, is very important in other cancers. And then vaccines are another strategy people are developing. This is the EGFR protein. It sits on the outside of a cell. And when it gets activated, it causes all sorts of changes in the cell that leads to new proteins being produced by genes that causes the cancer cells to grow and live longer, and new blood vessel formation, all the things you don't want a cancer cell to do. One of the ways we go after that, this is again that EGFR protein on the cell surface. The way it works is through this what we call tyrosine kinase domain. When you turn the protein on, it activates this part of the protein. And these drugs are Erlotinib, also called Tarceva, or Gefitinib, also called Arisa. What they do is they go in and they block this. So even if you turn it on, it doesn't work. You stopped it from being an active protein. And in the metastatic setting, people already have disease that's spread. We don't know how to cure, but these drugs have been shown to be helpful, where you can improve survival. You get some responses, and this is the metastatic setting just to show we know that these drugs can help people. That led to this big trial of people where they potentially are curable. And in this setting, it's going to be nearly 1,000 patients who have their cancer completely resected. They may or may not get chemotherapy depending on their choice and the choice of their physician and talking through it. But then they decide to go on the study, and if they do, they're randomized. And it's a 2-to-1 randomization, meaning that 2/3 of the patients will go on to get the active drug and 1/3 of the patients will get a placebo. And if they go on the active drug, they'll get 2 years of the Erlotinib or Tarceva, and if not, they'll be observed. Actually, it's with placebo, so you don't know what you're getting. The reason that we have to do a study this way is that even though we know that the drug can help people with metastatic disease, it's different in a setting where the disease has already been removed and you're trying to prevent it from coming back. And the biology, the way that it behaves, can be very different, and so we don't always know. We have to do these kind of studies to figure it out. I'm just going to talk about 2 other big studies that are happening with a similar sort of idea. One is looking at this angiogenic switch, which is the blood vessel formation. In order to go from a little tiny tumor here, 1 to 2 millimeters, to actually something that's causing a problem, you have to make new blood vessels. And this protein called VEGF is very important in that. There are now lots of drugs that target VEGF, one of which is an antibody called Bevacizumab or Avastin. And the way it works is it's just out in the circulation and it sucks up all the VEGF before the VEGF can bind to its receptor and start causing all the blood vessel problems. Okay, so that's the way it works. And this study showed that if you add this Bevacizumab to chemotherapy, again in metastatic disease, you can help people live a little bit longer and you increase the likelihood of the tumor responding to treatment. So that got everyone excited. Well, maybe this is going to help in early stage disease improve cures. So again, we know that adjuvant chemotherapy helps in resected disease. The benefit of VEGF was proven in advanced stage disease. So it made sense to look at this in patients where the cancers come out. We're hoping to improve the cure rates. And that led to this trial I'm going to talk about. And this is the ECOG 1505 trial. It takes all patients who have resected stage 1B, at least 4 centimeters, because we talked about smaller sizes, chemotherapy doesn't seem to help, to 3A, and it randomizes them to chemotherapy alone for the 4 cycles, or that same treatment plus the bevacizumab, and the bevacizumab is continued for 1 year. So that's another big trial where we're hoping to improve upon just the chemotherapy. And the last study I'm going to talk about is with a vaccine. This is a vaccine to a protein called MAGE-A3, which is only found in some lung cancers. It's not found in any normal tissue, and it's only found in about 35, maybe up to 50% of lung cancers in total. So it's not for everybody. But in the people who do have it, there was earlier trials where they gave the protein and something to really rev up the immune system to that particular protein, which is a strategy for all vaccines. In phase 2, where some of the people were getting this vaccine and some weren't, it looked really encouraging. And so that led to this randomized phase 3. And this is this trial. This is a big study. There are over 2,000 patients, and that's only about a third of patients, maybe half, have this protein at all. So you have to recruit lots and lots of people to do the test to see who has the protein, because only the people who have that protein are even going to potentially be benefited by the vaccine. So people are resected, they're screened, and if they have expression of this protein, they're then randomized to get the vaccine over 2 years or just to get placebo injections. In conclusion, adjuvant chemotherapy with this cisplatin drug plus another chemotherapy drug is the standard of care for patients with resected stage 2 and 3A lung cancer. If you have a stage 1 cancer, perhaps those with the bigger tumors are benefited, but those with the smaller ones aren't. The critical issues that we still need to look at, though, are how to better select patients. If we're only helping 5 to 10%, that means there's a big percentage that aren't being helped. We don't want to have those people go through chemotherapy if it's not going to help them, and we need to find better treatments to help those people. And so that's where we're moving, is finding better drugs and better patient selection. Thanks.